So, so over to you, Dr. Swati.
Thank you very much, sir. Good evening, everyone. I welcome you all to the RSA Research Society of Anesthesiology fortnightly webinar on this day, which we conduct every Thursday with different themes and topics. I welcome you all here and thank you for participating in various capacities. So there'll be interesting topics, two of them lined up for today. And before I begin, I would specifically like to thank Dr. Tej Kaul, who is the patron of the society, for mentoring each one of us to take this journey of research, academics, and clinical education forward. Thank you, sir. I thank Dr. Naveen Malhotra, President, Research Society of Anesthesiology, who has been very supportive and he is leading from the front while where it comes to all the activities associated with the society for the benefit of the students and the faculty alike. Thank you, sir. I also thank Dr. Vishal Singla, who has always been a pillar of support in conducting all these activities. He is very much enthusiastic about these activities and of course providing the logistics for that. Thank you, Dr. Vishal. I also now invite patron Dr. Tej Kaul sir to please say a few words, followed by the president and secretary. Sir, please.
Great pleasure to be a part of this academic webinar. A great job started by the worthy president and the secretary and the governing council, this academic exercise. It indeed is very, very informative, and my request to the organizers remains that kindly circulate the information of the webinars much in advance so that it has a wide publicity and every member knows about it. And this is my request. My best wishes for this academic exercise, and I'm sure it will be greatly beneficial to everyone whosoever listens to it. Thank you very much. Thank you.
Thank you, sir. Now I invite Professor Naveen Malhotra, sir, President, Research Society of Anesthesiology. Sir, please say a few words to the audience.
Thank you, Dr. Swati, for conducting this webinar today, which is being organized by RSA Jodhpur branch. And I welcome Dr. Shaikh Roy and dear Dr. Tanya Mittal, who shall be talking about mediastinal tumors and role of TE in non-cardiac surgery. And these two are very important topics, bit challenging also. And every day you do not see mediastinal tumors, and everybody doesn't have a TE probe in the department. So they will be ably guided by the chairpersons, Dr. Jyoti, Dr. Neha, Dr. Mrityunjay, and Dr. Rakesh Kumar. So I am very sure that all the delegates will have a wonderful time listening to the speakers and the discussions thereafter. Thank you very much.
Thank you, sir, for those kind words. It is understandable that being a working day at 6 p.m., most of the OTs are running about, and we also have viewership on the YouTube, and that recording on YouTube stays forever, and we are frequently getting views from topics which are specially meant for the postgraduates. So the number might seem less on the Zoom meeting right now, but these gain views live as well as the recorded sessions on YouTube. That's what we have observed, and it's our duty to keep the things on YouTube so that the residents can take benefit at their own convenient time. Next, I invite Dr. Vishal Singla to please say a few words before we proceed with the official academic program.
Good evening, ma'am. Good evening, everyone. Good evening to the President, Dr. Naveen sir, and Patron Dr. Tej Kaul sir, and all the dignitaries present here. It's my great privilege to be here, and I would welcome you to the two new initiatives by the RSA, which will be launched soon. One is the Yuva Oration, and the RSA times 3 would be launching very soon. And I also would like to congratulate Team Jodhpur for holding this webinar at such a short notice. Thank you very much. Thank you very much, ma'am.
Thank you, Dr. Vishal.
And also, Dr. Tej Kausar, your message has been well taken, and we will be taking care of it from the next time onwards. Thank you very much.
Definitely, sir. Yeah. We'll begin with this academic agenda for the day. For the first session, which is on anesthesia for mediastinal tumors, I invite my screen here. I invite the chairpersons for this session, Dr. Jyoti Sharma. She is additional professor at All India Institute of Medical Sciences, Batinda. Her areas of interest are onco anesthesia and critical care. She is associate editor of the Airway Journal and has been the organizing co-chairperson for the Society's annual conference in 2025 and North Zone representative for IDA. She has won Young Speaker Award at Criticare 2023. She has more than 60 publications to her credit and is a frequent faculty at various national and international conferences. I welcome you, Dr. Jyoti. Our next chairperson is Dr. Neha Goel, a very promising youngster in this field, assistant professor at Graphic Era Institute of Medical Sciences, Dehradun. She is interested in pediatric anesthesia and regional anesthesia. She's a holder of Indian Diploma of Regional Anesthesia and a BLS ACLS instructor. And she also has a certificate course in palliative care and published several papers. Welcome you, Dr. Neha. Now I request the chairpersons to take hold of the session and introduce our speaker and proceed with the talk.
Good evening, everyone. Good evening, sir. Am I audible?
Yes, you are, Dr. Jyoti.
Yes.
Okay. Good evening, everyone. So it's my privilege to be chairing this session, the webinar conducted by the RSA Jodhpur branch. So to begin with the academic session, I would invite our first speaker for the day, Dr. Shayak Roy. So he is working as an assistant professor of anesthesiology at Dr. Ramanohar Lohiya Hospital, New Delhi, and his areas of interest are oncoanesthesia, palliative medicine, and chronic pain. So I invite Dr. Shayak Roy to speak on the topic anesthesia for mediastinal tumors. So over to you, Dr. Shayak.
Thank you so much, ma'am. So, sorry, ma'am, I'm sharing my screen. Is it visible, ma'am?
Share it now. You will be able to share it now. Yeah.
Okay, ma'am. Is my screen visible?
Yes, it is. Please make it to the slideshow format.
Let's start our topic beyond the mass. Like, what is the perioperative management for the mediastinal tumor? Since I am an oncoanesthetist, this is like really this topic is very close to my heart because it is very challenging and also it is multifaceted. So let's begin with this case scenario, like middle-aged obese woman with shortness of breath on lying down, requiring 3 pillows to sleep with this chest, X-ray planned for sternotomy and resection of the retrosternal goiter with enlarged mediastinal lymph nodes. CT shows 60% compression of mid-trachea and deviation to the right and luminal narrowing of the SBC. So how do you proceed in this scenario? Keeping this case scenario in our mind, I am going to begin my discussion. The content of my topic will be based on introduction, then anatomy of the mediastinum and its contents, clinical symptoms, then key imaging, preoperative risk stratification, role of PFTs and flow volume loops, preoperative optimization, then anesthesia management, including airway strategies, then intraoperative monitoring and crisis preparedness, and postoperative management. So what I am not going to talk about is the DLTs and the one lung ventilation, which is associated with this kind of tumors. I'm not going to talk about the HITOC surgeries, which are like hyperthermic intrathoracic chemotherapy, like where cisplatin and doxorubicin are given, because it is entirely a different facet, and their anesthetic considerations are different. And I'll briefly touch the myasthenia gravis, which is the most common systemic manifestations of these tumors. So the mediastinal mass first intervention may have substantial morbidity and mortality because of the vicinity of the vital structure around. The collapse of these mediastinal masses on the trachea, chambers of the heart, pulmonary vein, and the superior vena cava could have disastrous cardiovascular and pulmonary outcomes. The collapse of the endobronchial tree is the most dreaded complication, especially when the point of tracheobronchial compression or collapse is distal to the tip of the endotracheal tube. So this is the anatomy of the mediastinum, which is divided into the superior, anterior, middle, and posterior, as the image suggests. So I'm not going into the details of this anatomy. Just for quick revision, I have incorporated it. What is more important, that what are the mediastinal masses that arises from these compartments? Like in the anterior superior compartment, 59% of the masses are malignant. But in the middle, 29% are malignant, and in the posterior, 16%. The most common anterior superior compartment tumors are thymomas. In the middle, it is lymphoma, and in the posterior, it is neurogenic tumors. This is the detailed list of all the masses that we can see in the mediastinum. Each one of them has different anesthetic consideration, but I'm not going into that. Broadly, we have to remember that thymoma, lymphoma, and neurogenic tumors are the most common mediastinal tumors. So let's come to the pre-anesthetic evaluation. The clinical feature vary according to the size and the nature of the lesion. They can be asymptomatic or incidental finding on routine X-ray or CT. The anterior and superior mediastinal masses, which are most common, they might also present with asymptomatic difficulty in swallowing, heaviness in chest with pain, sweating, headache, neck and facial swelling, venous distension in the neck, arms, and upper chest, and posture-related symptoms. The clinical features, like the severe symptoms, which are associated with the high risk of outcome, they are dyspnea at rest, stridor, orthopnea, syncope, and cough when supine. So while history taking, we have to be really mindful of these symptoms, whether they are present or not. Now, what are the compression symptoms? So if they are compressing on the tracheobronchial tree, stridor, dyspnea, which changes with the position, recurrent pulmonary infection, hemoptysis is the most common symptom, and the sign will be wheeze and decreased breath sound. If the compression is on the esophagus, predominant symptom will be dysphagia. If it is on the right ventricular outflow tract, then the symptom will be dyspnea and syncope. If recurrent laryngeal nerves are involved, then there will be hoarseness. And if the sympathetic chain gets stretched, then Horner's syndromes are likely. In the compression of the SBC, there will be dyspnea, cough, syncope, orthopnea, stridor, headache, and decreased mentation. And the signs will be venous engorgement, upper body edema, plethora, cyanosin, and Pemberton sign. So as we can see that the dyspnea is the most common symptoms, and but the signs are different. So we have to see that what are the actual signs to know from the history taking and physical examination that which structure is being compressed. So these are the some studies which have given good like explanations how this compression symptoms happening in large bronchogenic cyst or mediastinal seminoma or superior vena cava syndrome. So I have summarized them into this in the coming slides. The superior vena cava syndrome is one of the dreaded syndrome that we have to actively look for. Like, it's a critical condition in which an intrathoracic mass lesion which compresses the SVC. It develops in 10% of the patients with right-sided malignant intrathoracic mass lesion. The clinical features are that it presents with edema of the upper body, like face, neck, larynx, and upper limbs. There will be dilatation of veins like neck and thorax, and development of collateral veins if slowly evolving. There can be CNS symptoms like headache, visual distortion, and altered mentation, and respiratory symptoms due to compression of the airway by the tumor or engorged vein. So when the hands are low, as you can see, there is no redness of the face. But when the hands are up, the face becomes red because of the compression of the SVC. This is the CT picture, which shows the tumor. This is the tumor, and this is the ascending aorta. This is the descending thoracic aorta, and this is the pulmonary artery. Some specific issues which pertaining to SVC obstructions are that there is a possibility of excessive bleeding, uncertain drug delivery, and possibility of stridor and airway edema. So the urgency of therapy to relieve SVC syndrome, like endovascular stenting, radiation therapy, and chemotherapy, depends on symptom severity. Whether we should proceed with this case or whether we should go for stenting, radiation, and chemo, that depends on the emergency of the surgery and also the presence of the superior vena cava syndrome. So there is a grading of this compression syndrome, and they are graded in as asymptomatic, mild, moderate, and severe. In the mild cases, patient can lie supine with some cough and pressure sensation. In moderate, they can lie supine for short periods but not indefinitely. And severe cases cannot tolerate supine position at all. And while history taking, we should inquire what is the most comfortable position of the patient, which invokes minimum symptoms like head up or sitting upright or forward bending or lateral decubitus, and it should be documented. And during anesthesia induction and airway management, this is the position we should start with to prevent any occurrence of airway compromise and cardiovascular collapse. So these are the compression syndrome. Now let's look at the systemic manifestation. That what systemic manifestations this mediastinal tumors occurs. Like if it is a thyroid swelling, then there will be hypothyroidism feature or hyperthyroidism feature. And if it is a tubercular lymphadenopathy, pulmonary and renal involvement might be there because of the treatment or because of the tubercular involvement. Thymoma, which is the most common case. So 30% of the thymoma cases, there is associated myasthenia gravis, which is the most common systemic manifestation. If it is a sarcoid tumor, then and the treatment for the sarcoid is going on, then the steroid therapy should be initiated. And in case of neuroendocrine tumor, there will be headache, sweating, and hypertension. And we should aggressively look at which kind of hormones they are secreting. Apart from routine laboratory investigations, some chest X-ray, PFT, and 2D echo is of special interest if there is compression features. So as you can see from this chest X-ray, there is a compression at the carinal level. So in this kind of particular cases, we need to be really mindful. So TFTs are required for thyroid mass, VMA and metanephrine levels for neuroendocrine tumor, alpha fetoprotein and beta ECG for teratomas, electrophysiological test and serological test in case of thymomas, and proper histopathology diagnosis of the CT-guided biopsy should also be present so that we know that which tumor we are dealing with. CT scan is the modality of choice, and CT scan gives us accurate assessment of the tumor size, nature, extent, and relation to the tracheobronchial. Also, the airway diameters for formulating the airway plan. As you can see that it is in the same patient, the tracheal diameter is different in 3 areas. This is the trachea, and it is compressed by the tumor here a little bit down, and this is the level of the carina. So the level of obstruction and the diameter of the trachea at the level of obstruction we should find out. From the CT scan of thorax, we should measure the diameter and the cross-sectional area of the trachea, then mediastinal thoracic ratio MTR, and the mediastinal mass ratio. 30% decrease in the diameter of the tracheobronchial lumen is associated with respiratory symptoms, and more than 50% decrease may be associated with complete airway obstruction during induction and emergence from GA. The tracheal cross-sectional area is roughly by the formula, if we try to derive, it is AG in years divided by 9 plus 0.35 centimeter square. But from the CT scan, it is measured as a percentage, like measured area divided by predicted area multiplied by 100. Less than 50% of the predicted area have higher risk of respiratory complications and recommended that this patient should not receive GA. Mediastinal thoracic ratio is calculated by comparing the size of the mediastinal mass with diameter of the thoracic cavity. More than 50% has the highest risk of perioperative respiratory complication. So the difference between mediastinal thoracic ratio and mediastinal mass ratio is that here it is mediastinum divided by the complete transverse diameter of the thorax maximum, and this is the diameter of the mass divided by maximum mediastinal width. So this gives us a graded scale for small, medium, large, and like if the mediastinal mass ratio more than 56%, it correlates with increased perioperative respiratory complications. It is described by King et al. Now let's come to the pulmonary function test. In assessing the mediastinal tumor, peak expiratory flow rate reflects the central airway diameter. It should be performed in upright and supine position, and less than 50% of the predicted peak expiratory flow rate is associated with significant anesthesia complication. From these two parameters, if we combine, we get Schamberger risk assessment box, which shows us that if any of the parameter is if less than 50%, then the anesthetic technique of choice should be local anesthetic or GA with spontaneous ventilation, and we should avoid muscle relaxation. If both the diameters are more than 50%, it is low risk and we can proceed with GA. And if both the diameters are less than 50%, then we should proceed with local anesthetic only. Now, from the flow volume loop, we can find out that whether the obstruction is fixed obstruction or intrathoracic airway obstruction or extrathoracic airway obstruction. In case of fixed obstruction, both the limb, inspiratory and expiratory, will be truncated. In intrathoracic airway obstruction, the expiratory limb will be truncated, and extrathoracic airway obstruction, the inspiratory plateau will be truncated. So after learning all these things, we have to combine them to find out to calculate what is the actual risk. If it is an asymptomatic patient and mass and chest ratio is less than 0.2% and less than 50% or no symptom is there, and if there is no vascular compression, then it's a low risk. If mild or moderate or gradual onset tumor is there and patient can lie flat, or mass and chest ratio is between 0.2 to 0.5 with less than 50% symptom or more than 50% and no symptom or more than 50% due to goiter, then it's a moderate risk. If there is severe symptoms with acute onset like less than 6 months and cannot lie flat, and mass is to chest ratio more than 0.5%, along with abnormal PFTs, then it is a high risk. So chances of airway compromise in low risk patient is less than 2%, in moderate is 2 to 15%, and in high risk patient it is more than 15%. So in the preoperative management plan should be an interdisciplinary team plan with involving anesthesia, surgery, radiology, ENT, and pathology. Pre-op plan of radiation or chemotherapy to reduce the size of the tumor based on the histopathology should always be discussed with the medical oncology team. Then we should see and assess the size and the location of the mass. Then assign the risk class as we have discussed. Then enough staff should be present in high risk patient like a second anesthesiologist, nursing staff, and perfusionist. And optimization of systemic manifestations like myasthenia gravis, thyroid. So all those things should be properly optimized. Now, in the intraoperative management, From the anesthesia side, there should be flexible ETTs, DLT and bronchial blockers should be ready, and flexible fiber optic bronchoscope should also be present, along with rigid bronchoscope, jet ventilator, and cardiopulmonary bypass. From the surgery side, they should be prepared with rigid bronchoscope, tracheostomy instrument, sterile airway hoses and YPs, sterile flexible ETTs, and tracheoesophageal balloon for dilatation. Now, the transport of the patient should be in the most comfortable breathing position as discussed. And SVC syndrome patients should be transported with upper body elevated. Now, what are the major concern, or we are fearful of two major things which can happen during induction? One is airway or respiratory compromise or cardiovascular compromise. So, by reducing the function FRC, when we give GA, the lung volume is reduced by about 500 to 1500 ml due to decreased respiratory muscle tone. There is also loss of spontaneous diaphragmatic movement under GA with the use of muscle relaxant. So it eliminates the normal transpleural pressure gradient as compared with the spontaneous inertial anesthesia. The relaxation of the tracheobronchial smooth muscle enhances the extrinsic compressibility of the airways. The supine position causes an increase in the central blood volume, which also increases the tumor blood volume and its size. So rapid tumor enlargement due to hemorrhage and congestion can happen within minutes, and we should be prepared for it. With the change of its position under anesthesia, it exacerbates the airway compression. Spontaneous ventilation preserves diaphragmatic movement in a caudal direction so that a normal transpleural pressure gradient is maintained. It keeps the airway dilated, thus minimizes the airway collapsibility from the extrinsic compression of the mediastinal mass. And it must work out an appropriate anesthetic plan that will avoid the airway obstruction. And we should be ready with an alternative that will quickly establish the airway patency to restore the oxygenation. So, from all of this, we are able to understand that anesthetic plan needs to be individualized. We cannot just prepare a plan in our mind and go ahead with it. Every intestinal mass is different, so the anesthetic and surgery plan should also change along with it. Sedative premedication should be avoided. In SVC syndrome, Fowler's position should be used because it reduces airway edema. ASA standards of monitoring should be used. IV access, like 2 wide bore venous access, should be there. And IV access is preferable in lower extremities if SVC syndrome is there. CVC before induction should be considered in high risk patient and preferably in femoral vein. And TE should be considered if the mass is compressing the heart or alveoli, or if it is attached with the myocardium and pericardium and surgeon wants to excise it. Surgeon with a set of rigid bronchoscope must be present at the time of induction in case of an obstruction for ventilation distal to the compression. So the ideal position of the induction should be that causes least airway obstruction. So the plan can be no induction, like local versus regional. So in these cases, as we conduct, that we give epidural, and this is known as knee VATS or non-intubating VATS. Then the surgeon, then after putting the epidural, the surgeon incises the thorax, or aortic sternotomy is done. Aortic thoracotomy is done. And then if we want, then after nebulization, we can intubate the patient with aortic fiber optic. Maintenance of spontaneous ventilation, we're using small boluses of IV anesthetic like ketamine, propofol, etomidate is another option, or inhalation induction, but inhalation induction, it usually takes longer duration. Or it can be standard IV induction with or without muscle relaxation. Now, again, come back to this case scenario. Middle-aged obese woman with shortness of breath on lying down, requiring 3 pillows to sleep with, and CT scan shows 60% compression of mid-trachea and deviation to the right with luminal narrowing. This is the X-ray and this is the CT. So how would you proceed? So again, you have to see that this is a low risk or high risk. So this is a high risk case because in view of symptoms and CT scan finding. So awake fiber optic intubation is a technique of choice because it is safest, and it allows the inspection of the level of obstruction, diameter of the airway, And intubation should be distal to the level of tracheobronchial compression, for which the fiber optic is the gold standard. But after intubation, you have successfully intubated the patient, but and after giving muscle relaxation, so sometime later you find that the airway pressure rises about to 40 centimeter of H2O, auscultation reveals bilateral bronchi, and she starts to desaturate rapidly. What should you suspect? This, you should keep in mind that this is not a normal case. So the DD should exclude that there might be a compression uh, where the tip of the tube is, there might be a compression distal to it, and it should be quickly checked by the bronchoscopy. Pushing the endotracheal tube further may result in improvement of the scenario, because it is possible to bypass the obstruction even going into endobronchial tree. The presence of rhonchi might be misleading. We might think that bronchospasm is happening, and so rhonchi and high pressure is one of the DDs, but we have to rule out the major airway or central airway obstruction first with patient with mediastinal mass. Second DD, if the patient is desaturating, that we have to rule out the compression of the major cardiovascular structure compression by TE. So in spite of that, we have done everything, but patients start desaturating despite my attempt, the team's attempt to bronchoscopic adjustment of the endobronchial tube. Then what should we do next? So we have to alert the surgeon, because now it is the time for rigid bronchoscopy or proceed with the immediate sternotomy to lift the mediastinal mass. There is no other way. Jet ventilation and of the proximally intubated trachea we can try while the surgeon attempt all these things. But and also keeping in mind that changing the position of the patient sometimes might, not always. Even there, so if we have not given relaxant, or if we have sugammadex, then we can awaken the patient. That is also another option. We can apply CPAP. In rigid bronchoscopy, apneic oxygenation, ventilation through ventilating bronchoscope, or airway exchange catheter, loading smaller smaller diameter ETT through the bronchoscope distal to the compression are another methods. But ultimately, if all those things fails, then we have to go for femoral bypass, and we have to anticipate it prior. So during the management of the cardiovascular collapse, we have to keep in mind that fluid resuscitation, especially blood, may be needed. Inotrope and vasopressors are required. We should avoid vasodilators. Ultimately, as we have discussed, that immediate sternotomy, lifting of the mass, and femoral bypass is the preferred and the definitive step. And the need for the cardiopulmonary bypass should be elective. From the CT scan, we should find out that whether we are going to require it or not, because emergent rescue situation is unlikely to result in a favorable outcome. So the management of the intraoperative complication is divided into two parts: respiratory issues, circulatory issues. In respiratory issues, if there is impending airway collapse due to hypotension, we have to give rescue position, heliox, secure airway with rigid bronchoscopy. If isolated proximal or mid-tracheal obstruction, then intubation, stenting, and threading it distal via fiber optic is an option. But if it is a distal area obstruction, carinal obstruction, bronchial obstruction, then we have to consider ECMO. Also, if it is an impending cardiovascular collapse, then we have to find out whether it is preload dependent, or if there is associated RV and PA obstruction. In those cases, initially we can try fluid, vasopressors, rescue position, but if it fails, then ultimately ECMO is the choice. All these case reports, they support. I have taken my plan from all these case reports, and this is the intraoperative management which I have just discussed based on the low risk, intermediate risk, and the high risk. The airway management during the maintenance phase should be by the flexible bronchoscopy, which is gold standard, or video DLT, or crossfit ventilation. Like if the tumor or mass is infiltrating carina or the trachea, then tracheal resection is also sometimes planned intra. So that is managed by crossfield ventilation. The plan of analgesia is usually multimodal. I'm not going into them in details. For the extubation, like we intubate the patient for tumor resection or for biopsy also. If the tumor is resected and there is no tracheomalacia and there is normal pre-op PFT, we should extubate and observe on the floor. But if there is tracheomalacia or impaired gas exchange or peak expiratory flow rate less than 40% with mixed obstructive and restrictive PFT, we should extubate and observe and monitor in the monitored care setting like HDUs. And if with tracheomalacia, there is more than 50% tracheal and like there is major narrowing or low tidal volume is there, then we should consider delayed extubation, like preferably 1 to 2 days. And during this 1 to 2 days, we should consider stent, external stabilization, and initiation of other treatments. So the complications of the mediastinal mass surgery can be surgical complication like hemorrhage, nerve injuries, like phrenic nerve, recurrent nerve, SSIs, surgical site infection, mediastinitis. These are common complications. The non-surgical complications are respiratory failure, delayed extubation, pulmonary complication, post-op arrhythmias, which we anesthetists have to take care. Now let's come into the myasthenic gravis proper. The muscle weakness, which is fluctuating and worsen on exertion, is the key feature. Ocular manifestation usually comes first in these patients associated with ptosis and diplopia. Ptosis can be symmetrical, unsymmetrical, unilateral, bilateral. Other features like diplopia and nystagmus can be present, and pupil is usually spared. If the bulbar muscles are involved, then dysphagia, dysarthria, difficulty in chewing, nasal regurgitation, nasal twang, involvement of facial muscle and myasthenic nerve should be present. And in limb muscle, proximal muscles are usually involved more than the distal muscle. There can be difficulty in climbing, weakness of neck extension, dyspnea, and diaphragmatic movements. I'm not going into them in details. This Leventhal criteria is important because many examiners ask them. So if the duration of disease is more than 6 years, patient is assigned 12 points. Associated with COPD, 10 points. Pyridostigmine dose more than equal to 750 mg per day, 8 points. And vital capacity less than 2.9 liters, 4 points. So if the combined accumulated point is less than 10, patient can be extubated after surgery. If it is more than 12, then patient should require post-op ventilation. It is not a good predictor for transcervical and VAD surgeries, and these points can be reduced by preoperative plasma exchange and high-dose perioperative steroid and anticholinesterase. All the medications which are continuing in the pre-op area should be continued in the post-op also. The local and regional anesthesia should be used whenever preferred. Amide local anesthetics should be used as the first choice. Caution should be exercised when considering axial and brachial plexus blocks in those patients who have significant respiratory and bulbar weakness. And uraxial blockade to mid-thoracic level paralyzes the accessory muscle of breathing. So it should not be, so we should check the level till what the level is rising. So if there is residual paralysis, then we think it's a myasthenic crisis. If there is excessive reversal, it is usually cholinergic crisis. So neuromuscular blocking drugs should therefore be avoided whenever feasible. And they have profound sensitivity for the non-depolarizing muscle relaxant, and they have resistance to depolarizing neuromuscular blocking drugs. Like the ED95 of succinylmethonium is 2.5 times greater in patients with myasthenic gravis, and there is also increased risk of developing phase 2 block. The reversal with neostigmine is unpredictable, and risk of cholinergic crisis is there. So anesthetic plan can be non-muscle relaxant technique, TIVA, inhalation, or knee VATS, non-intubating VATS. Plan B is rocuronium if sugammadex is present with NMTs. Plan C can be cisatracurium. So these are my literature in the support of knee VATS and TIVA, which is coming up in a big way in these surgeries. They are saying that it is like muscle relaxation is not at all needed. So the combination of choice is rocuronium somatase. Neuromuscular monitoring is must. And if sugomate is unavailable, then neostigmine should be titrated to effect to avoid chronologic crisis. And while using NMT, the TOF ratio more than 0.9 or 90% should be confirmed as a minimum. These are the drugs which should be used with caution or best to avoid in patients with myasthenia gravis, like some antibiotics, aminoglycoside, fluoroquinolone, macrolides, beta blocker, procainamide, quinidine, botulinum toxin, chloroquine. The list is endless. And so no, I'm not going to discuss them because of the lack of time. So the take-home summary is that first to understand the anatomy of the anterior mediastinum, then recognize the common presenting symptoms of an anterior mediastinal mass, stratify the patient into low risk, moderate risk, and high risk, and formulate an anesthetic plan that emphasizes the maintenance of the spontaneous ventilation and appreciate the appropriate role of cardiopulmonary bypass electively, not as urgent. Thank you.
Thank you, Dr. Shayak, for a very nice presentation. You have beautifully summarized, starting from the anatomy, the clinical presentations, the different type of tumors that we can find in the mediastinum, and how we can actually stratify and formulate a plan of anesthesia. And it is very important to note that all these the plan of anesthesia has to be individualized and case-based. We cannot just go with single plan of anesthesia for anesthesia and mediastinal tumors. We are now open for any questions to Dr. Shayak, if any.
So yeah, I think in the chat box there is one question on.
There is a question in the chat box. Can
Yeah.
you take that question, Neha?
Yes, ma'am. So my opinion on the leak test in the large retrosternal goiter. So if there is tracheomalacia, then even if the leak test is negative and we take the tube out, then it might happen that the airway might collapse. So leak test is not very definitive in these cases. So the flow volume loop is going to give us better idea about the dynamic airway collapse than the leak test, because during leak test we are seeing the leak around the tube with the tube in situ, but what will happen after we remove the tube we do not know, because there can be tracheobronchial compromise. So in those cases which have tracheal compression, it is always better to withdraw the tube over the fiber optic and see the airway compromise or collapse, and then be sure.
So you would maintain the plane depth of anesthesia and reverse the neuromuscular blockade, of course, to see the spontaneous.
Yes, ma'am, and make the patient in the spontaneous mode and then check with fiber optic before removing.
You can also make a ultrasound to know the leak actually. It's very much becoming popular now. So that can be, it's a totally non-invasive way of doing it. Obviously, we can do that.
Yes, thank you, sir.
So very rightly said, Dr. Shayak, like in the both for intubation and extubation, maintenance of this spontaneous respiration is the key in these type of cases.
So if there are any questions, please raise your hand. You can unmute yourself and ask directly to the chairperson and to the speaker.
Tag, I have a question for you.
Yes, sir. Please, sir.
What if there is a limb? I just saw a patient. I want your opinion on that. There's a pediatric age group which is a lymphangiomatous patient, and there is a neck mass which is extending towards the intrathoracic extension and obviously extrathoracic extension also. So, what will be your approach for this patient?
So, sir, first I would like to see the CT, sir. Sir, what are the structure it is compressing, sir?
Like it's such a huge mass. We have got X-ray, but doing CT in this 5 months old baby will without sedation will not be possible.
Okay.
Mm.
Okay, sir. And sir, is the biopsy done or the biopsy is awaited? Like
It's more
it is a cystic
mainly
hygroma.
this differential diagnosis is lymphangioma and hemangioma. That is, that is
Okay.
with the tongue
Okay.
mass,
Okay.
tongue
Yes, sir.
swelling is also
Yes,
there.
sir.
Yeah,
Okay. Okay, sir.
I'm going
Sir,
bit off mark, but yeah, I think there's a march which is continuing from this to that. So we need to see how to do with such complicated mass. I've taken two messages I've taken from your talk was like obviously we have to preserve the spontaneous breathing as
techniques,
far as possible.
preserving
Yes.
spontaneous ventilation.
Yeah.
Yes.
And then
And sir, CTVS backup should be there with rigid bronchoscopy also.
yes.
And like rigid bronchoscopy and CTVS should be in the backup, sir. It should be taken up in the CTVS OT.
Okay. What do you think? What will be the role of video laryngoscope plus fiber optic combined technique in this particular case?
So the kid will not allow. So the kid will not allow, sir. Like if we deep the also, so awake check VL can be attempted, but since you're saying there is large tongue, so fiber optic is not suitable in this kid, sir, if the depth is not adequate. Check
So
VL first,
ketamine or
followed by check
inhalational for
bronchoscopy.
induction. Ketamine or inhalational for
Yes.
induction. Which one do you
Inhalation,
prefer?
ketamine or inhalation? Sir, inhalation.
Yeah. Okay. Thank you, sir.
Yes.
Anyone has any questions?
There are not any further questions. The topic has been very comprehensively covered by Dr. Shayak and ably moderated by the chairpersons. So I thank the chairpersons, Dr. Jyoti Sharma and Dr. Neha Goyal, and the speaker Shakra. You presented really well. So
Thank you, ma'am.
Thank you,
so much.
ma'am. Thank you so much.
so I'll quickly move on to the next topic for today. Next session for the day, which is regarding use of tea. So I invite the chairpersons, Dr. Mrityunjay Kumar. He's associate professor at AIIMS New Delhi. His areas of interest are cardiac anesthesia and critical care. He's a diploma holder in hospital management and obtained a clinical fellowship in liver transplant anesthesia from King's College London. He's on the editorial board for JOACP, Indian Anesthetics Forum, Critical Care Update, and he's national expert with the Government of India, Ministry of Health and Family Welfare, and also caters to the emergency care services at the district hospital. Thank you, sir, for being a part of today's academic agenda. I also invite and thank Dr. Rakesh Kumar to be chairing this session. He's additional professor at All India Institute of Medical Sciences, Jodhpur. His areas of interest are airway and cardiac anesthesia. He was awarded first prize for Dr. Usha Mehta Award in Dr. Usha Mehta Award in cardiac anesthesia at the recent annual conference of RSA at Indore. He was awarded second best poster during the IPSA conference, and he has more than 90 publications and 3 chapters in textbooks to his credit. Thank you, Dr. Rakesh, for joining us today, and I request you to please introduce our speaker and to proceed with the next academic agenda.
Good evening, everyone. It's a real privilege and proud moment of proud for me. One bright student after another bright student of my careers. So I'm talking about Dr. Tanya Mittal now. She's a assistant professor of cardiac anesthesia at RML Hospital, Delhi, and she has done MBBS from Lady Harding Medical College, MD from very much AIIMS Jodhpur, and DM cardiac anesthesia from AIIMS New Delhi. She was first rank holder during that competition there, and she also holds fellowship in transesophageal echocardiography and a certification from the EACVI certification. And she has also visited as an observer to the MGH Hospital, Boston, and she won a first prize in paper presentation at IAPTOCon. And Tanya, all the best for your presentation. And she's going to talk about like not use of transesophageal echocardiography in the non-cardiac surgeries. Over to you, Tanya.
Thank you, sir. So I would like to share my screen. So is my screen visible, ma'am?
Yes, it is.
Yes.
Thank you, sir. So at the offset, I would like to thank the esteemed faculty of the Research Society of Anesthesia to allow me to speak on this topic, and it's a privilege. Thank you so much, ma'am and sir. So my topic is transesophageal echocardiography for non-cardiac surgery. So starting with the TE, it is an ultrasound diagnostic technique using an esophageal window. It utilizes an electronically steered high-frequency probe, which is mounted on an endoscope. The high resolution coupled with anatomical proximity to the posterior cardiac structures delivers a superior imaging quality when compared to TTE. So the transthoracic echocardiography usually is used for viewing the anterior cardiac structures, and TE offers a better resolution for the posterior structures. So starting with the guidelines, the American Society of Echocardiography guidelines recommend a comprehensive transesophageal echocardiographic examination guidelines. And this can be referred to for all the views. And I've taken much of my presentation from here. So the indications, we focus on non-cardiac surgery indications. So in evaluation of structures, cardiac structures or aortic structure, where the findings will alter the management, and TT is non-diagnostic. So in patients on ventilators, for example, after a major trauma case, or in patients with ARDS where a transthoracic window is not being visualized, T can offer an advantage. In patients with chest wall injuries, for example, multiple rib fractures, flail chest, or extensive thoracic burns, where a TT probe cannot be used, we can use a T. And in patients with morbid obesity, where views are not seen on a transthoracic examination, and in patients where position is strictly prohibited to move to a left lateral decubitus, like a cervical spine injury or a patient with trauma, TE can offer advantages. Intraoperative TE, of course, in non-cardiac surgery patients where cardiovascular pathology may be pre-existing and we need a diagnostic information. And also in critically ill patients where diagnostic information in whom TT is not very useful. So, for example, if there's persistent hypoxia, persistent hypovolemia, where a TT probe is not adequately giving us the information, like a cardiac tamponade, in such cases, we can use a transesophageal examination. So the absolute and relative contraindications for T. So before performing any examination, we must know the contraindications. So where we will not use a T probe are absolute contraindications include a perforated viscous, esophageal stricture, any tumor in the esophagus, any perforation or laceration, or any diverticulum, and an active upper GI bleed. The relative contraindications include a history of radiation to the neck or mediastinum, any recent GI surgery or any recent upper GI bleed, a Barrett's esophagus, any varices, esophageal varices, coagulopathy, active esophagitis, and active peptic ulcer disease. So this is a table taken from the guidelines which shows the list of the complications with transesophageal echocardiographic examination. So overall, it's a relatively safe procedure and the complication rate is just up to 2.8%. However, the major contributors to the complication include a lip injury, which offers a 13% contribution, a hoarseness of voice, and dysphagia. So the pre-procedural preparation includes reviewing the patient's history, ruling out any contraindications, and obtaining patient consent. We should check for the mouth opening, any loose or artificial dentures before inserting the probe. And orogastric decompression is recommended because if there's air in the stomach, the visualization is hampered. So Rice tube may be inserted and there can be decompression done before insertion of the probe. A bite block should always be used to prevent damage to the probe, as well as the dentation and the lips of the patient. And ECG monitoring should always be attached to the echocardiographic machine for simultaneous correlation with the cardiac cycle. So these are parts of the TE probe. This is the handle of the TE probe. This is the body, and this is the tip. So it's almost like an endoscope. And this is the connector, which is used to attach to the echocardiographic machine. So in a close-up view, we can see there are the buttons. These buttons help in the omniplane angle adjustment. There are two wheels. One is the smaller outer wheel and the larger inner wheel. So the larger wheel is used for anti-flexion and retroflexion, the smaller wheel for moving the tip to right and left. So before probe insertion, we usually use the probe under GA, and the insertion is facilitated using a jaw lift and directly putting the well-lubricated probe towards the posterior pharynx, almost like an iGel insertion. The probe is inserted with a constant gentle pressure and in addition to a slight turning back and forth. And we must stop where there's a distinct loss of resistance, and slight flexing of the head of the patient or turning the patient towards the left, or the head towards the left, can help in insertion of the TE probe. Sometimes excessive extension of the neck can hamper in the insertion of the probe. So here we can flex, or we can even use a video laryngoscope to assist in the probe insertion. So there are specific terminologies used to describe the manipulation of the TE probe. So this is the tip of the probe. If we insert it further, it is known as advancing the probe. Removing it is withdrawing. Then rotating it towards the right or clockwise and rotating it towards the left. Then using the wheels, we can turn the tip anti-flexion or retroflexion, and the smaller wheel is used to turn the tip towards the right and left. There are also two buttons which are shown, and they are used to adjust the omniplane angle. So the omniplane angle can be adjusted from 0 to 180 degrees. So this is a small video. This is showing the handle of the TE probe. This is the handle, and this is a smaller wheel, the larger wheel, and two buttons for adjusting the omniplane angle, increasing and decreasing the angle. So now we will see the movements of the tip. So when we turn the larger wheel, there is anti-flexion. This is the anti-flexion movement of the tip of the probe. Turning it other way leads to a retroflexion of the tip of the probe. So now we will see the retroflexion. This is the retroflexion. Then the smaller wheel. Using the smaller wheel, we can turn the tip of the probe towards the left, and the other way we can turn it towards the right. This is the right movement. Now this is the clockwise rotation of the tip of the TE probe. We have to move the entire handle to move it clockwise and then anti-clockwise in the other direction. This is the anti-clockwise movement. Now here we will see the omniplane angle adjustment. So these are the buttons, and when we press it, here we can see the angle is increasing from 0 to 180 degrees, and the other button is used to decrease the angle. So here we can see. So now the probe insertion. So first we need to insert the bite block. This is important to prevent the injury to the lips and the teeth of the patient, as well as prevent the bite of the TE probe. And always remember to use adequate amount of lignocaine jelly. Now we use the T-probe, and slight anti-flexion is done to assist the insertion, and it is slid down the posterior pharynx of the patient. Sometimes it may be difficult to insert it like this. So here we can use a jaw lift maneuver to assist in the insertion of the T-probe. So now coming on to the standard positions of the T for imaging, there are 4 positions which are described: upper esophageal, which is 20 to 25 centimeter from the incisor; mid esophageal, which is 30 to 40 centimeters; transgastric, 40 to 45, and deep transgastric views, which are 45 to 50 centimeter from the incisor. So the indications of T in non-cardiac surgery: for elective use for rapid assessment of any anticipated hemodynamic changes and where its benefits are likely to outweigh the risks. The final decision is usually guided by the patient's medical status, the nature of the surgical procedure, and the special circumstances for the patient. There's another term known as the rescue T. Here, it is indicated in patients with unexpected or if there are unexplained hemodynamic changes, regardless of the surgical procedure or the patient's medical condition. So a rescue examination may be performed intraoperatively or postoperatively or in other critical areas. So specifically for preoperative identification, indications in non-cardiac surgery and rescue T include in high-risk patients with a known or suspected cardiovascular pathology, like a valvular heart disease, a coronary artery disease, or if there is a low ejection fraction. In patients suspected to have intraoperative hemodynamic instability or major fluid shifts, like in major vascular procedures, abdominal surgeries, organ transplant, and neurosurgical procedures. Also in patients with intra-abdominal tumors with IVC extension. It can also be indicated in patients with suspected cardiovascular pathology that might result in a pulmonary compromise, like a severe pulmonary hypertension or a significant shunting. In surgical patients with major abdominal or thoracic trauma, and in patients with instability presenting for emergent non-cardiac surgeries. Intraoperative indications may include unexplained persistent hypotension, which is not responding to any traditional therapy, or persistent unexplained hypoxemia, low cardiac output or heart failure, and intraoperative cardiac arrest. Postoperative indications may include hemodynamic instability, myocardial ischemia, or if we need to increase the vasopressor and inotropic requirements substantially, and we do not know the cause. So the American Society of Echocardiography recommends a 28-view comprehensive examination for transesophageal echocardiography and an 11-view basic examination. However, a rescue or a focused T examination may be performed in unstable patients, and there we can limit the views to allow a more rapid assessment. So this is taken from an article which recommends these 16 views for T examination in patients undergoing a non-cardiac surgery and limited views for rescue T. So one by one, we will look at these views. So starting with the home screen. So mid-esophageal 4-chamber view always is the home screen. So if we are lost during the examination, we're not able to view proper structures, so we always come back to this home screen. So this is at a 0-degree omniplane angle and the mid-esophageal level. Here we can see the right atrium, the tricuspid valve, the right ventricle, the left atrium, the mitral valve, the left ventricle, and the interatrial septum as well as the interventricular septum. We can also view the pericardium here. So now what all should we view in this image? So right atrium can tell us about any pressure changes in the right atrium. So if there is increased RA pressure due to a right ventricular dysfunction, the interatrial septum will move towards the left. Similarly, there can be any right atrial masses. And the tricuspid valve, we can see if there is any tricuspid regurgitation due to RV dysfunction in case of a pulmonary embolism. Or in left atrium, there can also be any mass or thrombus in the left atrium. And in the left ventricle, in this view, we can see the anterolateral as well as the inferoseptal walls for assessing any regional wall motion abnormality. Next, we go to the mid-esophageal aortic valve short axis view. So we increase the angle around 35 to 45 degrees, and we get this view from the previous image. So here we can see the right atrium, the right ventricle, the aortic valve, and the left atrium. This is the interatrial septum, and these are the three cusps of the aortic valve. So this is used to assess the aortic valve morphology. If they can be any bicuspid aortic valve, any aortic regurgitation in trauma patients, or aortic stenosis. Or we may also be able to see any dissection flap in the aorta in this view. Next, coming to the mediasophageal aortic valve long axis view. So this is focused on the aortic valve. We are not able to see the left ventricular apex. So here there is left atrium, the mitral valve, the left ventricular outflow tract, the aortic valves, and the proximal ascending aorta is visualized. So this is at an omniplane angle of about 120 degrees. And here we can take the left ventricular outflow tract diameter to assess the stroke volume. The second part of the stroke volume imaging I'll show later. So here we see the LVOT diameter. The aortic valve cusps can also be seen here, and the proximal ascending aorta for any dissection flaps, aneurysm, dilatation, atheromas, hematomas in trauma patients. So this view is important for that. Next comes the mediasophageal bicable view. So in this view, we are able to see the left atrium, the interatrial septum, the right atrium, the SVC, and the IVC. So here, if we have put a central line, we can visualize the tip at the SVC-RA junction and confirm its position. The IVC can show us some intracardiac masses, IVC thrombus, which may extend into the right atrium in certain non-cardiac surgeries. And interatrial septum is important to visualize any shunts like persistent foramen ovale or ASD. So usually there's a left to right shunt. However, if there is increased right atrial pressures, that can lead to a right to left shunting and unexplained hypoxemia intraoperative. Next, coming on to the mediasophageal modified bicable view. Here, in addition to the mediasophageal bicable view, which was taken at an omniplane angle of around 100 degrees, this is taken around 70 to 90 degrees. And here we can see additionally the tricuspid valve. So this is used to assess the tricuspid regurgitation and pulmonary hypertension. So when we put the continuous wave Doppler across here, we can measure the pulmonary artery systolic pressures. And if they are more than equal to 35 mm Hg, that indicates a pulmonary hypertension. Next, coming on to the mediasophageal RV inflow-outflow view. This is taken at an angle of around 50 to 70 degrees. And here we can see the right atrium, the tricuspid valve, the right ventricle outflow, and the pulmonary valve. And this is the left atrium and the aortic valve. So this view can give us information about any thrombus in the pulmonary artery, the MPA, or RV dysfunction, RV dilatation, any tricuspid regurgitation. And so this view is important for assessing the right ventricle. Next is the mediasophageal two-chamber view, which is taken at a 90-degree omniplane angle. So in the previous views, like modified bicable and bicable view, we turn the probe towards the right. However, in the mediasophageal two-chamber view, the probe position is neutral. So here we see the left atrium, the mitral valve, the left ventricle. In the two-chamber view, we see the anterior wall and the inferior wall of the left ventricle to assess for regional wall motion abnormality. And we also see the left atrial appendage for any clots. Next is the mediasophageal long axis view at an omniplane angle of 120 degrees. So between this view and the mediasophageal aortic valve long axis view, here we focus on the left ventricle and we can see the left ventricle apex. So this is the differentiating feature from that view. So here we also see the left ventricle walls, which are anteroseptal and inferolateral, again to assess for any regional wall motion abnormality or LV dysfunction. And additionally, we see the left atrium, the mitral valve, and the aortic valve, and the ascending aorta. Now this view is the mediasophageal ascending aorta short axis view at around a 0 to 10 degree omniplane angle. Here we see the SVC, the ascending aorta, and the main pulmonary artery going to the right pulmonary artery. So this view is important to assess for any pulmonary embolism. Here we usually see a clot or a thrombus in MP or RP if there is any evidence of pulmonary thromboembolism. You can also see the ascending aorta. So any dissection flaps or any aneurysm can be visualized here. Now going down and advancing the probe, we go to the transgastric views. This is the transgastric basal short axis view. So basal because we are able to see the mitral valve. So this is at a 0-degree omniplane angle, and the probe is anti-flexed using the larger wheel. So here we see the left ventricle, the interventricular septum, the right ventricle, and the mitral valve, the AML and the PML leaflets of the valve. Here we divide the LV into 17 segments, which we will discuss later. So 6 of these segments are in the basal view. So this is inferior, this is anterior, this is septal, and this is lateral. So anterior segment, anteroseptal segment, inferior segment, inferoseptal segment, inferolateral segment, and anterolateral segment. So these 6 segments can be assessed in this view to identify any regional wall motion. Also, any mitral regurgitation can be seen because of the leaflets. Further advancing the probe, we see the transgastric mid-papillary short axis view at again the 0-degree omniplane angle. This is, I would say, like the most important view which one should know in T. Here we can easily assess for regional wall motion abnormality. Also, we can assess for any volume deficit because of the kissing ventricles. So in the mid view as well, the cavity is divided into 6 segments again, and we can assess the regional wall motion abnormality. We can also see the interventricular septum, and if there is any flattening of the interventricular septum during high RV afterload. We are also able to see pericardial effusion. So this is the hyperechoic pericardium. So if there is any fluid, we will see it as a hypoechoic shadow here. And there can be a compromise in the RV or the LV diastolic filling. So I would say this view is very important, and everyone should know at least to visualize this view. Then the deep transgastric long axis view, which is taken when we again advance the probe and slight anteflexion at a 0-degree angle. So here we are able to see the LVOT and the aortic ascending aorta. So this is the LV, this is the LVOT, and this is the ascending aorta, the aortic valve. This is the interventricular septum and the right ventricle. So this view is the second part of the stroke volume assessment. As we've already seen, the LVOT diameter can be measured in the mediasophageal aortic valve long axis view. And in this view, we place the pulse wave Doppler across the LVOT to measure the LVOT VTI. And when we multiply it, we get the stroke volume. And then when we multiply the stroke volume with heart rate, you can get the left-sided cardiac output. So the cardiac output can be easily measured in this view. Now, aortic views, when we come to the mediasophageal level and we turn the probe towards the left, we are able to see the descending thoracic aorta in short axis at 0-degree angle. So this view is important to assess aorta for any intimal thickening, for any atheromas, any dissection flaps or hematomas. This view is also important to see the pleural effusions. Left-sided pleural effusion can be easily seen in this view because here is the left lung. So if there is any effusion, you see as a hypoechoic shadow. When we turn the plane to 90-degree in the same view, we see the descending aorta and long axis view. Again, the aorta can be assessed for the same pathologies in this view. So now coming on to the term rescue T. So rescue T is a new terminology for any examination ordered by a perioperative physician on an urgent basis for a patient with hemodynamic instability. So the indications could be unexplained persistent hypotension, and the causes may be pericardial effusion, a mass, a thrombus, a severe hypovolemia, RV or LV failure, any valve pathology or pulmonary embolism. In patients where there is unexplained persistent hypoxemia, the cause may be intracardiac shunts leading to a right to left shunting. And if there are escalating requirements of inotrop, we can use T to guide the fluid and vasopressor requirements. And in cardiac arrest, of course, first we go towards the ACLS protocol. However, later can be used to identify the etiology of cardiac arrest. And if there are persistent ECG changes or arrhythmias in the OR, we can use the T probe to assess for any regional wall motion abnormalities. So the questions that need to be answered when performing a rescue T are, so these are the 7 questions which will help you answer. So first is are the RV and LV contracting adequately? Are there any regional wall motion abnormality? Is the patient's volume status adequate? Is there a significant valvular lesion? Is there a ventricular outflow tract obstruction? Is there a pericardial effusion or a mass and a clot? So this is a proposed algorithm to assess during rescue T. So if the patient is hemodynamically unstable and we do not know what the cause is, first we go towards the transgastric mid-papillary view as discussed. So that was the most important pertinent view where we can assess the ventricular contractility. We can see the regional wall motion abnormalities. We can check the volume status of the LV, if it is hypovolemic or not, and pericardial effusion. If the patient still remains unstable and these are not the causes, we go towards the mediasophageal long axis views or four-chamber views, where we can assess the valves, the mitral, the tricuspid, the aortic valves, the contractility of LV and RV, any outflow tract obstruction in the long axis view, any shunting in the bicaval view if there is a PFO or an ASD, and intracardiac mass or clot. If the patient still remains unstable, we can go towards the modified bicaval or bicaval view, RV and flow view, and we focus on the right ventricle side. So is the right ventricle contracting adequately? Is there a tricuspid regurgitation because of RV dysfunction? Is there any shunting? And is there any pulmonary embolism in the PA? If the patient still remains unstable, we can go for an extracardiac examination for a pleural effusion. And still, if the patient is not recovered, we can call for help. So now going on to the clinical applications of TA in non-cardiac surgery. So a specific non-cardiac surgeries, we take a few examples. So first is the liver transplant surgery. The common T views which may help in these surgeries include a mediasophageal four-chamber view, which was our home screen, to visualize all the chambers of the heart and the valves. The mitral and tricuspid. Then the mediasophageal long axis can be used to assess the LVOT and the LVOT diameter for cardiac output measurement. The transgastric mid-papillary short axis view to assess the contractility and preload. The modified hepatic vein view. So these are the views which can help us assess any IVC thrombus or stenosis in the anastomosis. And the deep transgastric views to evaluate again the cardiac output. So this is the lower esophageal hepatic vein view, which are the additional views given by the American Society of Echocardiography. So these were not in the views we discussed. So here we advance the probe from the mid-esophageal slightly to go to a lower esophageal level. And at an angle of around 20 degrees, when we turn the probe towards the right, we can see the right atrium, the IVC, and the hepatic vein. So here we can assess for any stenosis, any IVC thrombus, and diameter of the IVC to assess the preload status of the patient as well in these cases. Now coming on to the major vascular surgeries like the aortic surgeries, the pertinent views here are mid-esophageal aortic valve short axis view, as we've discussed. This is the aortic valve morphology. The mid-esophageal long axis view to see the ascending aorta, proximal ascending aorta for any dilatations like aneurysm, any hematomas, intramural hematomas, or any dissection flaps. And ascending aorta short axis view to see the upper part of the ascending aorta. And descending thoracic aorta, short and long axis both views, as we have already discussed. So here, this is the first view. Here we can see that there's slight thickening of the descending aorta. So this is the descending thoracic aorta, short axis view. And this is a slight intimal thickening, which can be in atherosclerosis or a coronary artery disease patient. This is the second view. This shows us the distal aortic arch. And here, when I play this, you can see that there is a intimal flap. So this is a dissection flap. This is another view in the abdominal aorta. Here we again see the dissection flap. So we can identify the falls in the true lumen. So you might think that this is the true lumen. However, there are certain points which helps us differentiate the two. So in systole, this lumen is expanding. So this is the true lumen, and false lumen is usually larger than the true lumen. Dissection, aortic dissection. There can be webs also in the false lumen. So this is how we differentiate. Next comes the neurosurgery, posterior fossa surgeries, where there is sitting position. So in these patients, the mid-esophageal bicaval view, the RV and flow outflow view, is important to check for venous air embolism. As little as 0.02 ml per kg of air can be visualized. We can also see if there is any paradoxical air embolism due to a PFO or an ASD. If there is increased right-sided pressure, there will be right to left shunting, which can lead to paradoxical air embolism. The transgastric views, mid-papillary short axis for hemodynamic monitoring, and mid-esophageal four-chamber RV inflow outflow view for any massive air embolism and detection of right ventricular dysfunction. and they can be interventricular septal shift and reduced RV contractility. So this is the mediasophageal bicaval view. Here we see that there is a ASD. So there is a large ASD here. The septum is not present in interatrial septum. This is the left atrium, right atrium. And we see that on color Doppler, there is a left to right shunt because the flow is blue and blue goes away. So our T probe is here, so it is a left to right shunt. However, if the right atrial pressure is increased, this can lead to a paradoxical embolism. Then coming on to trauma surgeries, the views important for these surgeries include the transgastric mid-papillary short axis, ascending aorta short axis, mid-esophageal four-chamber, and deep transgastric views. So these views can help us evaluate the causes of shock. They can be pericardial tamponade, pulmonary embolism, hypovolemic shock, cardiogenic shock, which can be seen in these views. And we can also assess for fluid responsiveness and cardiac output monitoring. And descending aortic views can be used to see if there's any thoracic aortic injury, including flaps, as we have already seen. So this is the transgastric mid-papillary short axis view. So this is that view which we saw. And here we can see the pericardial effusion. So this is the pericardium and this is the fluid which is collected in the pericardium. So this can lead to an obstructive shock in patients with trauma. This is a mid-esophageal ascending aorta short axis view showing the ascending aorta. Here should be the SVC and the PA, pulmonary artery. Here we see a hyperechoic shadow and this is the thrombus. So this is a pulmonary embolism. This can also lead to an obstructive shock in patients. Now preload assessment, here we see the left ventricle, so the transgastric mid-papillary short axis view. In cases of hypovolemic shock, we can see here that the ventricle is contracting, but these are kissing ventricles. It is completely collapsing in systole. So the patient is hypovolemic. And in this view, we see that the cavity is collapsing. However, this view, in this patient, there is left ventricular hypertrophy. And so we cannot comment on the volume status. So this is like, in these patients, we should be careful before commenting on the volume status in this view. We can go to the IVC view and assess the collapsibility of IVC instead. So this is a hypertrophic cardiomyopathy patient. Next, these are the views required for assessing the cardiac output. So the LVOT diameter and mid-esophageal long axis view and the pulse wave Doppler and the VTI across the LVOT, which gives us the stroke volume. And when we multiply it with the heart rate, we can see the cardiac output. This is the descending thoracic aorta short axis view. And here, as we discussed, we can see the pleural effusion. So this is the massive pleural effusion on the left side, and this is the collapsed lung. So this can lead to unexplained hypoxemia. This is a 17 segmental model for regional wall motion abnormality, which is important to assess the left ventricular systolic function. These are the mid-esophageal views, and we divide it into 17 segments: the basal, the mid, the apical, and the apical cap. So these are the names of the 17 segments. And in the short axis view, mid-esophageal short axis view, and basal view, we already discussed the 6 segments. So 6 segments each in these views. Then the apical view, 4 segments, and the apical caps is the 17. So this is the LV systolic function assessment in the mid-papillary short axis view. Here we see the inferior, the anterior, the septal, and the lateral. So the supply is different for each region of each segment. So that is how we pinpoint that which segment is involved and which artery is involved. So here inferiorly, RCA supplies it. Anterior and anteroseptal is usually by the left atrial, by the LAD. Left anterior descending, and the lateral is usually by the left circumflex artery. So this is how a loop shows some dysfunction of the LV. And when we compare it with another view, here we see that the dysfunction is even more severe. So the contractility is reduced. This is a loop of a patient with renal cell carcinoma who came to us for a RA thrombectomy. So we saw the IVC thrombus was extending into the right atrium, and we had to go on CPB to take out this thrombus. Thank you.
Yeah, nicely presented, Tanya.
Thank you, sir.
So one query from Dr. Swati. She queried that has the adaptation of T in trauma patient has improved outcomes? What does literature says?
So yes, sir. Thank you for the question, ma'am. So yes, so I took my presentation from 2-3 articles which have definitely shown that sensitivity of tea in patients with trauma has led to improved outcomes. So the literature says around like they took out of 100 patients, if they took around 70 to 80% patients had improved outcomes if the tea was used in trauma patients. But however, we need to look carefully about the contraindications and avoid in patients having any coagulopathy or if there is any cervical injury or any contraindications which doesn't allow a T examination. So yes, they have definitely improved outcomes in trauma patients.
Okay, I have some theories.
Stop sharing,
What about?
Tanya.
Okay,
Yeah.
yes, ma'am. Continue.
No,
Stop sharing,
I
yes,
was
ma'am.
just
Please.
asking her to stop sharing.
Yes, ma'am.
So I have one query that what is the learning curve of T in non-cardiac anesthesiologist? Because T is the domain of cardiac anesthesia. So what is the learning curve for non-cardiac anesthesiologist?
Yes, sir. Thank you for the question, sir. So I think the best time or the best utilization during MD, which I would say whoever gets the opportunity to all the students, that if you have a cardiac posting, please do utilize that because that is the point where you will get the hold of the T probe. Because transthoracic echocardiography, we all do it. However, T is like the complete opposite of that. So without
Yes.
practice, I think it's difficult. I understand that. However, there are a lot of conferences now which have a T simulator. So you
Okay.
get the feel of the probe there as well, but practice makes perfect. So.
Okay. And again, that you summarize that for non-cardiac surgery, 16 view is there. So does it for every patient it's required, or there are certain that these are the best view that you should look, or all 16 views one has to be look in all patients?
So, sir, it's difficult to see all the 16 views in all the patients. So it's better to prioritize. I would say like the algorithm was there. So if there is any hemodynamic instability, first we always go for the transgastric mid-papillary short axis view. I think that view is gives a lot of information. Along with that, mediastinal 4-chamber will give you a lot of information. That's the home screen, gives all the valvular information, RV, LV, and ascending aorta. So the aortic pathologies can be seen in those views. Bicaval view for right ventricle. So I think these 4-5 views will give you a lot of information quickly. So these are like the most important ones. And I think it should be individualized depending on the case.
Okay. Yes. Well, Matyunjay sir?
Hi, Tanya.
Yes, sir.
That was an extensive, lucid, and very well presented presentation. Yeah. So I'm really happy that we could be heard to this talk. I just want to make few I want to give some clinical vignettes. I'm a non-cardiac anesthesiologist who is working in a non-cardiac setup. So I'll just share my clinical vignettes right from the head to toe. I'll just tell you how this PE was utilized in my clinical experience. First of all, in neurosurgery, there was a case of oxygen embolism because of hydrogen peroxide infiltration, and we got the since TE probe was in situ. It wasn't happening in the sitting position, so it was detected. That air embolism or oxygen embolism, if you call it, it was detected immediately and it was aspirated, and we had a good result with the patient. Then again, there was a case of hysteroscopy patient. Okay, and it was happening in the lithotomy position and with the head low, and they kept on increasing the hysteroscopy pressure from that air pressure from up. And what happened? Patient collapsed. So we didn't know what was the cause. Luckily, we had a ST probe next OT, which simply put it, and we found that it was an embolism which happened again. And so we knew that this is a patient who can be revived if the embolism, air embolism can be corrected. So we did CPR for almost 1.5 hours in this patient, and patient went discharged from the hospital. Okay. Again, talking of the RCC, every time we see whether there is a thrombus in the renal vein or extending upper in the IVC all, because there are always chances of that embolism happening there also, and it can be a difficult one to resuscitate. So if you use a TE probe, we can always see the extension, what is happening in the intraoperative period. We can see and we can simply work on it, how to liver transplant again. whether to give fluid, whether patient needs anotropes or vasodilator, whether there is any anastomotic problem, IVC, that anastomosis site is having any thrombus or not. All these things can be ruled out through the TE probe, and it can be very well utilized. Then we also did one study where in orthopedic surgery, where the bone cement was being this thing, and we saw what is the incidence of bone cement embolism in orthopedic surgery, like those who are undergoing TKR on THR. So it was found almost in 100% of the cases. So I think this is a time the focus should be extended to the to the extended focus, and T, because to TT is very much being utilized. TE can also come into practice in all the cases, including trauma. Dr. Rakesh and Dr. Swati was talking about, because obviously those patients where we cannot do transthoracic echo, which is a part of the trauma management, we can very well go for TE, because you said that thoracic injury. There are some cases where we cannot put transthoracic echo probe on that. So TE will do wonder in those scenarios. Thank you again.
And sir, how long we kept that TE probe? Because like in liver transplant is run 8 to 10 hour, 12-hour surgery. So can we keep this to throughout that surgery, or there is time limitation?
It is not required. It is not required. When you need to, only thing is you should look for the contraindication. Esophageal varices, grade 3 esophageal varices, grade 4 esophageal varices should not be there. We can whenever in doubt, we can simply put it and we can rule out. It's not that we have to keep it continuously. It's not that required. Okay. Thank you.
Yes. Okay. Any other queries? I think there's no. So,
Thank you very much, chairpersons and Dr. Tanya Mittal, our excellent speaker for the day. Thank you. And if anyone wants to add their experience, I know we have just reached the stipulated time, but if anyone wants to add to the experience or whatever was discussed here, they have their own experience, that would be wonderful to share here regarding mediastinal masses as well as applications of TE in non-cardiac surgery. So please unmute yourself, show hands, or turn on your video and ask or comment or share your experiences. So I don't think there are any further comments in this regard. So
talking about the PG students, that Tanya was pointing out. Tanya was one PG who got exposure of TE in the PG period, and she is the rank 1 holder now in cardiac anesthesiology. She's soon to join as assistant professor in AIMS Delhi. And talking of another institute where they don't get exposure, it's a premier institute about the cardiac. And from that side, I don't see many DM cardiac anesthesia, or for that matter, those who are going to use TE in the future. So yes, whenever you get a chance to hold the TE probe, please do hold the TE probe, get hold of it. And that is applicable not only to the students, for all of us actually.
Yes.
And it is quite clear from today's academic session that TE is not just for cardiac surgeries. So even if you don't plan to be in cardiac anesthesia, or plan to be practicing as cardiac anesthesiologist, still there are so many indications outside the cardiac OTs, and you can make a difference wherever the decision making is tricky, or you're in some dilemma.
Yes,
it's always good to have this experience. Dr. Vishal, do you want to add anything here, or we can close this session?
Thank you, ma'am. I think it was a wonderful session, and all the topics so wonderfully cleared, ma'am. I think we are bang on the time, and we meet next fortnight, ma'am.
Yes, definitely.
Yes.
Thank you. And I put on record my gratitude to all the speakers, Dr. Shayak, Dr. Tanya. You have been wonderful in accepting our invitation last moment, and for all the chairpersons who joined and being part of the RSA team. obviously we work as a team. Thank you to everyone, our president, Dr. Naveen Malhotra, patron, Dr. Tej K. Kaul, secretary Dr. Vishal Singla, and all the GC members who have joined today, taken out their time, residents and other senior faculty from across India. Thank you to the audience who have joined today, and we hope that this exchange of academics through the medium of Research Society of Anesthesia continues. The webinars will be here every fortnight and also available on YouTube. So you can share the YouTube links. I'll also share in the respective groups to the residents so that everyone can benefit from what the updated literature. Thank you. Long
Thank you,
live
Dr.
us.
Swati.
Long
Thank you.
live us. Good night, everyone.
Thanks.
Good night.
Good night. Long live RSA.